Well, good morning. My name is Dr. Donna Hubbard McCree, and I serve as the Associate Director for Health Equity at the National Center for HIV, Viral Hepatitis, STD, and TB Prevention. I have the honor to welcome you to the Dr. William Bill Jenkins Health Equity Lecture. This lecture honors the late Dr. Bill Jenkins and recognizes his outstanding legacy of innovative public health action, his dedication to the elimination of health disparities, and efforts to promote the highest ethical standards in public health practice. We collaborated with Dr. Jenkins' wife, Dr. Diane Rowley, to develop a lecture in his honor that will focus on initiatives to improve health for communities of color and efforts to promote public health ethics, social justice, and health equity. I now welcome Mr. Greg Bautista, who is a health scientist in the NCHHSTP Office of Health Equity, and he will provide some opening remarks. Mr. Bautista.
Thank you, Dr. McCree. It's a privilege to share how Dr. William Jenkins' legacy continues to impact our health equity efforts and paves the way for future leaders in public health. Dr. Jenkins began his career at CDC in 1967 as one of the first African Americans to join the U.S. Public Health Service Commission Corps. In 1980, he joined NCHHSTP in what's now known as our Division of STD Prevention. While here, he served as a statistician, epidemiologist, and chief of the Research and Evaluation Statistics section. Additionally, he managed the Tuskegee Participants Health Benefits Program, which provides medical care to the survivors of what's now known as the Public Health Service Study at Tuskegee. In the spirit of Dr. Jenkins' vision and commitment to righting the wrongs of that infamous and highly unethical syphilis study, and ensuring that such things do not happen again, the program expanded to include a public health ethics fellowship and an annual intensive public health ethics course. In 2001, Dr. Jenkins led the development of the NCHHSTP Minority Health Strategic Plan, which called for establishing an Associate Director for Minority Health in the NCHHSTP Office of the Director. The position of the Associate Director for Health Disparities was ultimately created, along with a more expansive Office of Health Disparities, which is now our Office of Health Equity. After the office was established in 2003, Dr. Jenkins retired from CDC, and I had the privilege of meeting him in 2016 while supporting internships at NCHHSTP with Morehouse College. There I learned that Dr. Jenkins had founded Project Imhotep at Morehouse College in 1981 with support from NCHHSTP. Project Imhotep is an undergraduate public health summer internship program for developing knowledge and skills in biostatistics, epidemiology, and occupational safety and health. NCHHSTP has supported Project Imhotep since its inception. Each summer, several NCHHSTP colleagues serve as mentors for scholars in Project Imhotep. It's exciting to see that CDC's support for the future of our public health workforce has grown substantially over the years, thanks in part to the inspiration of leaders like Dr. Jenkins. In fact, the CDC Office of Minority Health and Health Equity today coordinates CDC's support for several public health career development programs for underrepresented minority students. It's exciting to see that this support has grown so substantially. And in addition to supporting Project Imhotep, the Office of Minority Health and Health Equity supports several other fantastic programs that host hundreds of underrepresented students each year. You can learn more about the eligibility requirements and the application process for CDC internships and fellowships by visiting the links that my colleague posted in the chat box. Clearly, Dr. Jenkins' leadership and service extended far beyond CDC, and it's a privilege to honor him today. I'll now turn it over to Dr. Diane Rowley. Dr. Rowley is board certified in pediatrics and preventive medicine, an emeritus professor of the practice of public health, and a senior researcher at the University of North Carolina, Gillings School of Global Public Health. She is also the wife of the late Dr. Bill Jenkins. You may learn more about her by viewing her complete biographical information at the link pasted in the chat box. Dr. Rowley?
Thanks so much, Greg, for describing some of the work that was so dear to Bill. My family is very honored to have this health equity lecture series named for him. I met Bill in 1980 when I was an EIS officer at CDC. 3 years later, in the fall of 1983, we were married, and our daughter was born in 1988. We had a wonderful family life. But today, I will make brief remarks about Bill's community organizing skills as part of his professional life. Wherever he lived, he was always organizing people. My generation likes to talk about what life was like back in the day. So I'm going to share with you 3 short stories from 3 different decades about Bill's organizing back in the day. Slide. Bill spent almost all of his career at CDC, and his first job was at the National Center for Health Statistics, where he was recruited into a biostats training program after he graduated from Morehouse College. Probably around 1968, he organized an underground community of Black federal public health workers. He circulated an underground newsletter called The Drum. The Drum was how he got the word out about his concern that the Tuskegee syphilis study of the Negro male was unethical. The group alerted the National Medical Association and several newspapers about the study, but they were unsuccessful in getting anyone to pay attention. In 1980, when he joined the Division of Sexually Transmitted Diseases at CDC, there were only a few Black people in positions in epidemiology, biostatistics, and laboratory sciences. So he decided to bring the Black people there together socially with the goal of getting us to trust each other and learn how to informally exert influence on CDC. In the early 1980s, we'd been getting together on Friday evenings for happy hour under the name Social Health Society. When Helene Gayle arrived as an EIS officer, she influenced Bill to get the group to do what today would be called good trouble. For example, in 1985, when the report of the Secretary's Task Force on Black and Minority Health was issued, marking the first time the US government had comprehensively documented health disparities, she led the group effort to plan how to get CDC to promote more activities on what at that time was an emerging issue. By the early 1990s, Bill felt comfortable moving from organizing underground and informal groups to directing the establishment of a national organization. That's when he created the Society for the Analysis of Public Health Issues, or SAFI. SAFI began in 1991 when an ad hoc executive committee that he organized convened the first meeting in Atlanta, just prior to the American Public Health Association meeting that was also being held in Atlanta that year. Once again, Helene Gayle was co-lead of that process. Bill was committed to using public health as a means of addressing injustice and inequity. Throughout his life, he worked on creating scientific knowledge, on developing a diverse public health workforce, and on building organizational power to improve the health of underserved populations. Reflecting on his activities back in the day, I think for him, the greatest compliment that he would want would be to be called a drum major for social justice. And now I'll turn it over to Miss Ati Pazarai, and I apologize if I mispronounced your name. She's a 2013 alum of Project Imhotep and health communication specialist with the National Center for Immunization and Respiratory Diseases. She will introduce and interview our featured speaker, Dr. Helene Gayle.
Thank you, Dr. Raleigh, and good morning, everyone. It's an absolute pleasure to be here. My name is Ati Pazarai, and I started my career in the field of public health in 2013 through Project Imhotep. My experience with Project Imhotep was nothing less than profound. From diving into extensive educational training courses in public health to gaining lifelong mentors, Project Imhotep certainly made a positive impact in my life. And as a matter of fact, through the relationships I made from Project Imhotep, I was fortunate enough to continue my journey in public health by working with CARE, an international humanitarian organization, and conducting qualitative HIV research in West Africa. Speaking of CARE, I'm very excited and humbled to introduce our special guest, Dr. Helene Gayle, a former president and CEO of CARE. Today, Dr. Gayle is the president and CEO of the Chicago Community Trust. But by the end of this month, Dr. Gayle will start her new role as the 11th president of Spelman College. Dr. Gayle, we're so thrilled to have you join us today. And I'll kick off the conversation by asking you a couple questions so that our audience can get to know you better. Does that sound good?
Sounds great, and it's my honor to be here. Thank you.
Thank you. So let's get started. So as someone who has devoted much of their career in the field of public health, can you share your career path and the inspiration for your pivotal career choices, including addressing health equity?
Yeah, so thank you. And let me, if it's okay, just say a couple of words, and maybe that's one of our questions, but you know, I just want to say, being a part of this seminar and recognizing the legacy of Bill Jenkins is, you know, kind of overwhelming. And, you know, Diane in her comments mentioned some of my collaboration with Bill, and we used to have this joke that he said, people will listen to you. So I'm gonna plant the idea, you go out and be the front person and I'll be back there making sure you keep moving it on. So we had this wonderful good cop, bad cop relationship that I think allowed us to do things that neither one of us could have done together. And I, you know, also before I answer your question, you know, several times people have referred to Bill as the late Dr. Bill Jenkins, and obviously we know he is no longer physically with us. But Bill was always early. He was never late. He was always at the tip of the spear and leading all of us in so many important ways. So anyway, just a homage to Bill and all that he did for me, for public health more broadly. But let me, you know, just to say, for me, you know, I grew up at a time and in a family where giving back was really all about, you know, the ethos around us. I grew up at the time of, you know, I think of it as the movement time. It was the civil rights movement, it's the women's movement, anti-apartheid movement, all of these issues that were going on that gave us a sense of wanting to be part of something bigger than ourselves. And so for me, I knew that I wanted to have a career that allowed me to give back, and particularly give back from the standpoint of equity and social justice. And, you know, I guess I was practical enough to decide that medicine was a tangible way to do that. But as I was going through my training and focusing primarily on the skills of being an individual practitioner, I realized that if I wanted to have an impact on being able to actually address issues of inequity at a population level, that public health was really the way of kind of marrying my political, my social aspirations with my chosen profession as a physician. And so that, after finishing my pediatric training, led me to the CDC to do the Epidemic Intelligence Service and ultimately the preventive medicine program. And I laugh and say I came to CDC thinking that I would do a 2-year epidemiology training program and maybe return to clinical medicine, and I stayed for 20 years. So that was kind of the beginning of my career that really, I think, helped me to actualize and realize why I started on my path to begin with.
Thank you, Dr. Gayle. So you mentioned, being able to address, or how you started addressing health equity. And since you work so closely with Dr. Jenkins, and reflecting on Dr. Jenkins' dedication to, mentorship, public health ethics, and health equity, how have you introduced some of those aspects into your work as a public health, development, and business leader?
So, I think that throughout, when I look at the threads of my career, having gone from individual clinical training to public health, then to economic development on a global level, and now here where I am at the Chicago Community Trust, looking at economic development at a local level, all of those issues are so intertwined. And we always talked about how the lived experience and everyday life of people is probably more important in many ways to their health outcomes than how many times they go to a doctor or how many times they access healthcare. And so for me, this notion that we didn't call the social determinants of health until a decade or so ago has always been front and center, recognizing that we do have a fragmented health system here in this country, and there's a lot more that we could do to get a more equitable health system in terms of people's access to clinical health. But we now know that 60 to 80% of what determines one's outcome, one's health outcome, is about the neighborhood you live in, the food you eat, whether or not you have stable housing, whether or not you have stable employment, what level of education you've been able to attain. And all these things are really the things that are more predictive of one's health outcomes. So I try to infuse that in all of the different arenas that I'm in, because I believe it is only through integrating health issues with the rest of how people live their lives on a daily basis where we're going to get the kind of outcomes that we want in terms of health equity.
I absolutely agree. Thank you for that. And I'm sure it wasn't always easy juggling those different characteristics, because we know with any career choice, there will always be obstacles in one way or another, which leads me to my last question. Reflecting on your career to date, what challenges did you experience in advancing health equity, and what opportunities did you leverage to navigate through those challenges?
The biggest challenge, and we may talk about this more, is that those of us who are concerned about health outcomes often work in a narrow health box, and it may be clinical health or it may be public health, but oftentimes the tools that we have available to us may or may not be the levers that we need to pull to be able to have the impact. And I think this challenge of how do we better integrate our systems so that the things that impact health beyond the health and public health system are able to talk to each other, are able to think about how we create seamless systems for individuals and communities to be able to do that. I also think the other factor that I'm so pleased that CDC is now talking about is systemic racism. We know that we have a system in this nation that has robbed individuals from realizing their full potential. And until we attack systemic racism and realize its impact on health, and particularly health of Black and Brown citizens in this country, indigenous populations, we are not going to be able to have the impact on health. And so, a lot of what we need to do is to think about how do we change policies? How do we look at systems differently, so that we're going beyond thinking about individual and short-term fixes to thinking about the longer sustainable fixes that we need to do at a systemic level.
Thank you, Dr. Gayle. So we've made it to the end of our interview, and we truly thank you for sharing your insights with us. But most importantly, we want to thank you for your ongoing commitment to health equity. I'll now turn it back over to Dr. McCree. Thank you.
Thank you, Ati, and thank you for that interview. And now I'd like to invite our special guest, Dr. Helene Gayle, and the director of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, Dr. Jonathan Mermin, to the conversation. In the interest of time, and so we can have a very robust discussion, my colleague has pasted a link to the complete bios for our guests in the chat box. So please feel free to click that link if you'd like to view the complete bios of all of our guests and our speakers today. All right, so I have this question I'd like to first pose to Dr. Gayle, and that would be, while people are thinking of questions they'd like to ask, I think it might be good for you to tell us a little bit more about your work at Chicago Trust and how your focus on economic development helped to advance health equity in Chicago.
Thanks so much for that. And as I look back over my 5 years here and, beginning and in the midst of a transition to my new role, it's wonderful to reflect on how we have really tried to shape our priorities here at the Chicago Community Trust. And when I came, the Chicago Community Trust, which is the community foundation for the Chicago region, did not necessarily have a unifying focus. And, like so many foundations, we had an arts and culture section, we had an education section, we had a health section, et cetera. But there wasn't this kind of sense of, what could we do that could have the longest term impact? And, while I came in as a health professional, and many people may have thought that I would have taken on a specific health issue or, the issue of public safety and violence that is so front and center in so many of our urban areas. But when we stepped back and thought about how could we have the most sustained impact in a way that touched on health and education and violence prevention and so many of the other issues, we recognize that underneath all of this, one of the most important root causes was the economic inequity that's faced here in our region and so many other urban areas. We're in a region where 2/3 of our population are Black and Brown. Mm-hmm. You can't expect that the Chicago region or any region that is, like so many cities, majority minority, can move forward if you're holding back 2/3 of the potential of our citizens. And so we said that we would put our energy against the focus on closing the racial and ethnic wealth gap because we felt it would be the most sustainable way of having an impact more broadly on issues like the life expectancy gap, like the access to quality education gap, like the issues of gun violence and public safety. Chicago has one of the largest life expectancy gaps in the country, 30 years difference between people who live in rich neighborhoods in the north side and our downtown area to those who live 5 miles away in our Black and brown communities. 30 years difference in one city. And if you look at that 30-year gap, so much of it is linked to these broader social determinants of health. So we felt this is where we could have our greatest impact. And so as a health person, I came in and, and have learned a lot about economic development and how do you really think about closing this gap that has always been linked to the racial and ethnic segregation that we also face in this country.
Yeah, thank you. Thank you for that. All right, so this question is for both of you. So looking back on the past few decades of work, are there any key policy strategies that you wish had been put into place early on that would have advanced health equity in HIV, viral hepatitis, STIs, or TB in the United States? And I'll start with you, Dr. Merman.
Thanks very much. And I wanted to also just thank you, Dr. McCree, for inviting me to participate in the panel, and for Dr. Gayle, a great friend, mentor, and founding director of NCHHSTP, who really left her legacy of doing good out of the pain of that comes from poor public health, and so we have spent a lot of time trying to do the kinds of things that she is so good at. So I appreciate that, Dr. Gayle. What comes to mind are three policies that were important but put in place later than I wish they had been, and one that has not yet been implemented. First would be marriage equality. Like racism, homophobia and transphobia are integrated into society and affect us in our daily lives. And if we had addressed the discrimination inherent in marriage inequality sooner, I think we would have prevented more STIs and HIV and supported the humanity and dignity of everyone in the nation. The second is healthcare reform. In addition to Medicaid expansion, requiring the coverage of preventive health services with no copay changed the cost of preventive services. And we still need to see it fully implemented. But having PrEP and STI testing, hepatitis A and B vaccines, screening for HIV, viral hepatitis, STIs, and LTBI, all covered with no copay, makes staying healthier a great deal easier. And it puts a dent into the massive disparities that we see because of societal racism, xenophobia, and homophobia. The third is syringe services programs. Appropriations law prevented the use of federal funds to support SSPs for many years. And there was only a 2-year break about a decade ago. But recently that restriction was changed and syringe service programs have proliferated. It was a conscious effort by CDC and partners to do this, and having Congress and the administration make a powerful statement set the groundwork for changes in many states and local jurisdictions. And I think supported the efforts to normalize syringe service programs, that they're seen as an integrated part of the public health system, just like we would for a community health center or a STI clinic or a TB clinic. And then the fourth, I hope can be in place, would be the implementation of a new approach to mental health. Entangled with all of the diseases, conditions, and behaviors we address at NCHHSTP is our collective failure to effectively prevent and ameliorate the effects of mental illness. Mental health and substance use are public health issues as well as medical ones, and yet policies currently in place, from an inability to prevent adverse childhood experiences to limited mental health insurance coverage, from physical and sexual violence to approaching drug use as a crime rather than a health issue, all leave our nation less well off than we would want it to be.
Thank you. Dr. Gayle.
Yeah, thanks. And I meant to also say how wonderful it is to be with you, Jono. And I will also say, you have a lot of hard jobs, but having added an additional H to what was already a long name. We all used to, when we were naming the center, we already thought HSTP, NCHSTP, and now you got your second H. But anyway, great to be with you. So, I will say, ditto to the things that John mentioned. And I maybe talk perhaps less specifically about particular policies and more, perhaps a bit more generally and globally. First of all, from a public health standpoint, I just think we need to have a commitment to public health that this nation has never really seen. And as we saw and witnessed during the start of the COVID pandemic, there was a lot of scrambling, and there was a lot of scrambling because, we do not fund public health like we do other urgent issues. And so, although I don't like to make military comparisons, we would never underfund our military in between wars. We're trying to hopefully never have to have, major warfare. But we would never say, let's underfund the people who will protect us if we need it. But we do that to public health all the time. And we do not, funding goes up when there's a crisis, funding goes down when we think that crisis is over. And so first and foremost, I think a commitment to public health in a way that sustains the workforce, sustains our surveillance systems, sustains all the efforts, our laboratories, and better knits them together so that we actually have a national public health system, and that is linked with our health system. Because we have a huge disconnect between clinical and individual health and public health. And we just definitely need to think about those as much more integrated and much more essential. And that linked to, what we have as an incredible biomedical research industry, but we see those as separate pieces. They're not as integrated, and particularly public health does not get the support it needs. So that, first and foremost, when we think about what could we do differently, I would add to that we need to continue to remember that we're part of the global world, and that more and more the issues that we're dealing with are global public health issues. And, again, we go back and forth between, are we part of this globe or are we an island unto ourselves? Every time we do that, we pay the price. Secondly, I think that we should think about what are the kinds of safety net guarantees that really address some of the social determinants of health. We saw during the COVID pandemic a huge expansion of things like the child tax credit, taking young children out of poverty, best health intervention we could have. So why can't we put some of those things into place on a more permanent basis? We gave people cash to pay their bills so that they were not homeless. Huge health impact of that. Why can't we think of things like a guaranteed income for poor individuals? So I think that there's a lot of things that we should be thinking about that look at how do we making sure that the richest nation in the world is providing some basic ability to live a life with dignity and a life that allows for the basic needs in ways that we haven't. And again, thirdly, I think addressing this issue of race and racism, which is clearly such an important part of our unfortunate history of health disparities. And, we saw that during the COVID pandemic, clearly the impact that it had on communities of color. And I think until we start addressing bold solutions to redress some of the inequities and some of the obstacles that have been placed in front of people, we're not going to have the health outcomes we want. So I think we have to address all of these issues if we're serious about, how we move forward as a nation.
Yes, that's great. And thank you. And I think the comments that both of you made actually relate to the next question, which is, there's an increasing openness now in the country to really discuss some of the social determinants of health that you just talked about in your responses. And many of the drivers, such as inequitable distribution of wealth, racism, and homophobia, are outside sort of the day-to-day influence of public health institutions. So what can people at CDC do to influence the main causes of health inequity? And this time I'll start with you, Dr. Gayle.
Well, I think first of all, talk about it. I think there's just an openness to talk about these issues differently. And I think also reaching outside of our health boxes that we're in to talk to our colleagues in education, in housing, in economic development, et cetera. And I think by helping to break down some of these silos, we can really create solutions that are, very, very different. As an example, here we have a program that we funded called Housing Plus. And it's a program that, is based on the premise that if people have stable housing, they will be able to take their medications, they'll be able to get more stable nutrition. There's so much that goes into what does it mean to have an address? What does it mean to have a stable place to live? So I think the more we can start thinking about these kind of integrated programs that actually look at this and understand that, we get funded in different silos and different buckets, but we can break through some of those by just really thinking creatively about how do we integrate these programs and talk across. So, I just think the more we can talk about these issues, the more public health becomes central to discussions at other tables, at the education table, at the housing table, at the economic development table. I think bringing public health into everything, is an important aspect of how we can do better and learn from each other.
Yeah, great, Dr. Merman.
I agree with everything Dr. Gayle said, and I would say that also, Dr. Burton will be also citing some of how we've kind of taken a dual role of both ensuring there's equity within our center, for both with workforce demographics and workforce experience, as well as working in kind of public health equity in the world around us. And so that will kind of set the stage for both parts. But I do think this is one of those situations where sound science, strong commitment and an open discussion can move mountains. One of the obligations of those of us at CDC is to collect and analyze data that allow us to measure social determinants of health rather than the markers of their influence, which is what most disease surveillance systems and studies do, and share that information with agencies and communities and institutions that have the power to change the underlying drivers that Helene had mentioned. Another is to conduct studies and evaluations that not only identify the most important social determinants of health, but what policies have resulted in changes in health outcomes, ideally for the better. And then this often takes complex multi-level models and creativity, but I think it can provide really meaningful results. And another is to think about policy and law as a public health tool and to support their inclusion in our work and that of our partners, especially federal, state, and local governments, and use that approach to disseminate guidance on the policies and strategies that will increase equity.
Okay, great.
Can I just add one other thing? And, I think about my days when we worked on HIV/AIDS and, developed, something that was very new to CDC, which was directly engaging with community and community organizations. And I think so often when we talk about solutions, we forget about the voices of community and including the voices of community. And we're not going to have solutions that matter to people's lives unless we have them at the table, helping us to think through what do they most need, what are the most practical solutions for their lives. And so I just want to add to all of this, making sure that we're having opportunities to listening to the voices of the communities that we serve.
Outstanding, of course. Thank you for that. And I also see that we have a number of questions in the Q&A, and I'm going to say to our audience, please continue to submit your questions using the Q&A feature. And I also would like to take this time to acknowledge and extend a special invitation to any of our past and present CDC Cup students or Ferguson Fellows who are joining us. We really like to see questions from our students who are participating in programs like at Morehouse, Columbia, University of Michigan, UCLA, and the Kennedy Krieger Institute. So please feel free to submit your questions. And also when you do that, let us know what program you're in. right, so I'm going to start with a question from our Q&A section here. This says, thanks for the presentation and the discussion, and this is for both of our presenters. Based on your experience, what can you tell young professionals at CDC to pursue in order to see our agency embrace health equality and DEI as an important part of our future? What can the next generation focus on to move us forward? Who'd like to begin with that one? That's a wonderful question.
So John, since you're at CDC, I'll let you start.
There you go.
Thanks, Helene. A lot of it we touched on is thinking about how you can make the biggest difference. And I think what that raises for us is, how do we incorporate doing a good job in this arena into our day-to-day work? A lot of that is our responsibility, wherever we are. You know, I mean, when you're thinking about the studies that you're designing, think about this. When you're devising or revising your surveillance systems, or you're analyzing data, what are you analyzing it for? And what are you going to use the results for? And how are you going to use it? When you're implementing a program, how are you engaging with the communities most involved? How are you designing that program? And how are you helping it to flourish? Who is implementing it? All of these questions, I think we are empowered to work with. And we don't know all the answers as individuals. We won't, but that's part of the benefit of working in public health is more than academia, sorry, Helene. They're actually, we work together as a team often, and we are able to kind of come together and help each other move forward as to make the differences that we want to see.
Great.
I guess I would just add to that, and this is not just CDC, this is more broadly. I think that understanding that internal in our organizations, we have people who have a range of lived experiences. And if we don't allow for a workforce that is truly inclusive and lets the voices of the range of people that we have, it doesn't matter how diverse we may look, but how are we making sure that we are giving voice to and giving support to people who want to raise these issues? And so I think there's a large role, not only in terms of how an organization like CDC or other organizations that are focused on these issues of health equity and equity more broadly, how we engage with our external partners, but how do we actually do that hard work internally as well, so that the voices, of people who want to raise tough issues are supported. And I think about that in the context of this lecture named in honor of Bill. As Diane said, in the very early days, it was really tough to raise some of these issues and be supported, and not feel like your career was at risk, or you had consequences, or you were made to feel less than. And so I think there's internal work for every organization to do, as well as we're thinking about the external focus that we want to have.
Great, thanks. And because we have so many questions, I'm going to continue to get some from the audience. Here's a great one. How has the concept of trust come into play in your work?
I'll just say it's quick and then turn it over to you, Jonah. We saw this with the COVID vaccine 10 times over. We were very involved in trying to increase rates of COVID vaccination in the communities that were most hard hit. And we did several, to your point about the importance of data. We did surveys that looked at, why were the rates different? What was it that made some populations willing and others not? And in the beginning, communities of color were not accessing vaccines at the same rate as the majority population. And when we looked at the surveys, particularly later on, in the beginning, it was lack of access to the technology to make appointments, or lack of access to vaccine sites. They were not understanding or not knowing where they could go to get vaccines. They were more like informational and access gaps. After working hard, and our Department of Public Health here really did a great job of, improving access in a variety of different ways and getting the information out there. But what remained the barrier, and we saw this particularly in Black populations, was the sense of trust. People did not trust the vaccine, did not, trust something that came from the, quote, came from the government. And we know we have this long-standing issue of how people have been treated in our health system. We talk about Tuskegee. Yes, that's a metaphor, if you will, for the broader issue of mistrust, but it's not Tuskegee. It's people's everyday experience with the health system. And so, we've got to be trustworthy if we want people to trust. And I think building that sense of trust is something that we all need to think about as, job number one, if we want to have an impact on, people's ability to access the services that will make a difference in their lives.
Great. Thank you, Jono. Dr. Merman.
Thanks. I think, your question of how do we assume good intentions in an environment of structural racism and homophobia? I mean, that's hard, because we have facts that show that we live in an unequal society. And I think, as Dr. Gayle mentioned, that what happened with COVID in terms of increased incidence of infection and mortality, as well as decreased access to vaccination or use of vaccination, it wasn't an active effort by the public health system to cause disparities. It was that in an unequal society, disparities will naturally occur and get worse in infectious disease if you don't do something very specifically to prevent them from occurring. And so I think we need to talk about it, and we need to win trust when it's necessary by documenting that things are working or changing things that aren't working. I also think something that Dr. Gayle mentioned earlier on, which is we have a very robust community engagement activity in our center. We fund community-based organizations. We fund programs that are ensconced in the community with engagement with others, but to try to do the best. It's participatory program implementation, like participatory research, and those kind of things can also help because people are part of the solution and realize that we're working on this as a team together. But I also would just want to acknowledge that I think the question is real. It's hard in the society. It's hard when we don't control communications in any way like we might have in the past. And so what it means is you may be doing great work and people still don't trust you.
Yeah, very good. I'm just going to continue to answer some of these questions because they're just very thought-provoking, and I think then we'll come back to some others. So there are several questions, Dr. Gayle, about you becoming the next president of Spelman, and a lot of congratulations around that, and some questions around public health loans and the cost of higher education. And we're going to give you time to answer some of those questions. You can also type your answers there. There are some others too around, here's one, Black folks, Black women in particular, seek information about experiences with bias, racism, sexism, et cetera, at hospitals. How can we begin to gather and share that information? So, and I guess, I'll leave it up to you guys, which one of you want to start with that question.
Yeah, go ahead, John.
No, I think you have, I was going to defer to you, Helene.
I'm not sure I quite understand the question.
So, and this is my interpretation, yes, saying that Black folks, Black women in particular, seek information about experiences with bias, racism, sexism at hospitals, i.e. there are data that talk about the experiences that Black women have at hospitals related to bias, racism, and sexism. How can we as an institution, I'm thinking, begin to gather some of that information and share it? What would be a way that we could share about Black women's, Black folks' experiences at hospital with bias, racism, and sexism?
Yeah, so I guess I'm not sure that and maybe it is true that Black women get more of their information from hospitals. I didn't, I think these days we get information from everywhere, including, unfortunately, from websites that actually promulgate myths, and so, I think that in general, we need to figure out what are great, unbiased, evidence-based sources of information, the CDC being one, but there's a variety of them. And I think the more we have messengers that people can trust, back to our issue of trust, and how can we work through whatever the organizations are that people are most trusting of, whether it's your church, whether it's your sorority, whether it's your civic organization. I think we, again, to the message of how do we infuse public health into the major organs of our society so that people are hearing messages in different ways, because we all know that everyone needs different messages, different messengers, and that we need to hear things several times. I still think of the times when I interact with the health system myself personally. I'm a trained physician. Somebody mumbles some information to me about, care. And then I get home and I'm like scratching my head saying, now, what did they say? And if I have that experience of, now, did they say I was supposed to do this 2 times? Did they say I was supposed to do it 3 times? Exactly how was I supposed to do it? If I have that confusion, that people who are untrained and don't understand biology are having that ultimately. So if the question is that our health systems are doing a bad job of health education, I would wholeheartedly agree. And again, I think that's where some of the community-based organizations and other can be so important. I just think again of our experience with HIV/AIDS and how important it was that messages were given in barber and beauty supply shops, places that people were. We educated those people to be health educators so that the only interaction that you get around your health and wellness was not at a place that only had 2 minutes to give you instructions.
All right, great. Thank you. Dr. Merman, did you want to add anything?
Only that I hope that the knowledge and kind of can be tied with action, so that if we do identify these problems, we fix them. And we've had some success in some of our programs and funding where we actually allow and even encourage those kind of changes, so that either of a friendly clinic or a friendly place where you will be welcomed, and a provider who is positively engaging to all communities, and I think that can be very helpful too.
Great. Okay, I'm going to take one more from the audience and then we'll come back. This is, how can we intentionally integrate and incorporate health equity and other DEI initiatives into health programs and organizations? And the question is, what I've seen over the last few years, especially with social justice reckoning since George Floyd, has become a checkbox for some organization when it comes to DEI work. The DEI health equity should be what we do as a community, organization, and an individual. So understanding that tools, resources, investments, training, and time are some ways we best integrate these efforts. So the question was, how can we intentionally integrate and incorporate health equity and other DEI initiatives into health programs and organizations? And I guess I'll start with you, Dr. Merman.
I think we have to treat it seriously. Once you realize that part of getting the public health job done is reducing inequity, then you pull in all the knowledge, science, program, procedures, change your administrative procedures, do what you need to do, because that's the goal, just like it used to be to prevent COVID or to prevent salmonella infections, or in our case, to prevent STDs. You have to use all the skills, all the teamwork, and focus on that as an important outcome. The other is something that I think you have led, Dr. McCree, with Captain Burton, is in the center, is really embedding this conceptual framework into how we work on a day-to-day basis, and incorporating what I think the question incorporated DEI, which is like, my workforce. How are we treating people? How are we creating a supportive and inclusive environment that is allowing all of us to flourish? That's tied in with how well we do externally. And I think if we do both of those things, we can succeed. But it also is having leaders who care. If you're going to hit your head against a wall if you don't have someone who cares, and you can, as someone else said, hold them accountable, make sure that we have measures that monitor whether we're successful, whether it's public health measures or other kind of internal workforce measures. I think in this society, we will never be perfect, just like any country I've lived in. They're never going to be perfect. There's going to be discriminatory practices, and there's going to be injustice, but we want to lessen it as absolutely much as possible. That's our goal.
Great. Dr. Gayle, did you want to add anything?
Little to add, I would just say ditto, and I do think, the importance of measuring and holding ourselves accountable. What gets measured gets done, as people say. And so, to the questioner's point, it is about intentionality. And if you're intentional, just like anything else, you can get it done. So.
Okay, yeah, and building on that, and I'll just answer this, and this is from a former Ferguson fellow, talking about the current environment that's resulted in this renewed focus on health equity. And those of us that have been doing this a long time knows that, there's the ebb and flow where you don't necessarily. How do we keep the momentum going to keep health equity as a priority once we return to a normal environment? And that's how it's described in the question. How do we keep this momentum going? Keep health equity as a priority?
Well, I would just say, I think of it as analogous to how the business community is thinking about sustainability, DEI, social issues. Health professionals and public health professionals, if we want to impact our bottom line, if you will, which is making sure that we have improved health outcomes in this nation, we can't do it without addressing these issues. We just will not. The reason that we have one of the highest maternal mortality rates in the industrialized world is because of our wide gaps and the disparity we have. So if we want to improve any of our health outcomes, we've got to address the issue of health disparities, and therefore we put into place all the things that Dr. Merman talked about that are critical if we're going to have an impact on health disparities.
Great. Dr. Merman, did you want to add anything to that?
I'm with her.
Okay. All right. What key partnerships do you think we need to advance equity when we talk about policy programs and economic development? What are the key partnerships that we need to really advance equity? And I'll go with you, Dr. Merman.
I think we've touched on some of them. It's thinking carefully about which partnerships are going to lead us to the outcomes that we want. And sometimes they're not always the easiest or the ones you immediately think about. So you need federal agencies to do the right stuff. Congress needs to be a partner. We need to be able to engage at the highest levels, not just to convince people about things, but to tactically figure out what's going to be the most effective ways of moving forward. We need our health departments and state legislatures and local health departments and legislatures, and we need communities. Whatever that is, and communities vary and intersect and everything, but we need those organizations. We need communications. And I think it's been a big gap for us in public health and CDC, is that we haven't been able to stay on top of the use of digital media and communications and micro-influencing and large-scale influencing in a way that industry has. And that's left us behind. And I was struck by the example that during a certain period of the COVID epidemic, someone did an analysis of Facebook and found that 50% of the misinformation related to COVID was coming from 14 Facebook accounts. So you're sitting and, well, what about reversing that and making it positive? Can we, as public health, essentially use this as a way of reaching people and improving public health and decreasing inequities? And I would say that the monkeypox response that's been happening now has been, in many ways, a success story in terms of getting information out through the digital streams and methods that people who are currently at risk for monkeypox are using.
Yeah, great. Dr. Gayle, did you want to add?
I just think we have to keep thinking about the fact that, so many of the solutions are not necessarily within one agency. And I think, both, as Dr. Merman said, federal to local, so vertical as well as horizontal, if you will, thinking about all these systems, how do they interact? And I think, continuing to think about what are the key other drivers, housing, education, et cetera, that can also have an impact, and making sure we're having those kind of partnerships as well.
Great. Okay, and again, we have some really wonderful questions from our audience, and some of them I'll just share. Again, Dr. Gayle, congratulating you on being the president of Spelman College. You have next incoming, you have a lot of individuals who are saying they're Spelman alum and are looking forward to sort of having you on board. There are some questions, and again, we'll share these with you about the cost of higher education. And the need to sort of thinking about public health loan forgiveness and whether or not that's helpful to the public health workforce. And there are questions around medical schools and institutions that educate public health professionals, preparing their students to be more productive contributors to the solution. There's several there, and research programs that motivate powerful people to really prioritize socially and economic environmental benefits. I'm sharing some of the feedback. And then there's a question, I think this is a great one, about incorporating global policies into our current public health practice and the bioethical implications of some of those studies. That came from a former MOTEP student. And the need to really address early career professionals and assisting them with mentoring and meditating on long-term goals, careers, and how do you kind of get through feeling sort of overwhelmed when you're doing those types of things. They're asking really questions about, sort of being able to prioritize and move forward in your plans for the future in terms of your career. And I would like to ask this one live. When you move into these cross-disciplinary, multi-institutional collaborations and you bring public health into an economic development and education, how do you set a baseline understanding and common language to achieve common goals through different approaches? So how do you really work with all of these different institutions, different disciplines, towards achieving health equity? How do you really set a baseline understanding and sort of common language? So let's ask that one.
Yeah, I don't know that there's, one right answer. I think, partnership and collaboration takes time. And I think we often think, we throw around these buzzwords of collaboration, partnership, and integration, and we do it with the same staff who have other things on their plate. Yeah. I think that the only way that collaboration happens is that you resource it appropriately, so that in fact people have the time to get to know each other. People have the time to discover what their shared values and shared objectives are. And without that, you end up potentially going to a lot of meetings that put a burden on your schedule but don't accomplish anything. So I just think if we're going to think about doing things in a different way and in a more integrated way, we have to resource it appropriately and make sure that people have the time they need to actually make those partnerships a reality.
Great. Dr. Merman.
I agree completely. I think another kind of tactical tool is to bring people together and get the job done, is to set a goal that forces people to do that. Like, you know, health in all strategies, for example. So if you're the Department of Labor, or you're the, the Housing and Urban Development, you're kind of forced to think about the influence on health. You have to think about how I can improve the health of the people who are receiving the services of which I'm providing, or provide my services to people in a different way, or to different people, so that those can be implemented. And so in a way, it's if at the top you come together, figure out one thing that you would like to get done, bring partners together, and then have assigned kind of very simple, understandable tasks, I think that can be successful too.
Yeah, and I just totally want to just emphasize, the tangibility, because oftentimes we think of these things in these grand conceptual and don't bring it down to, like, what's the 2 or 3 things we can all agree on, and set those goals and targets, and then set the metrics so that we're actually, evaluating and holding ourselves accountable.
Great. I have 2 more questions. This one, since both of you are physicians, I think is a great one. And this is from a student at the Morehouse Project MOTEP program. And he asked of Dr. Gayle, but Dr. Merman as well, both of you are physicians. So what current barriers do you feel have been the most influential in the disconnect between public health and clinical care? Barriers that you see have been the most influential in sort of, and then this is assumed there is the disconnect between public health and clinical care. Anyone want to go first there?
I can, if it's okay, I'll put out 2. I don't know which one. I haven't done a careful analysis. I would assign a team to do that, and then they would come back with some great advice. But what I would say, there are a couple things. So one is the hodgepodge of insurance and coverage and lack thereof that still exists in this country makes it hard for us to provide preventive care and good, equitable care as clinicians. It's harder to access things. I was presenting earlier today to a group of state legislators, and one of the topics that really came up for them as particularly painful from health and justice standpoint was hepatitis C treatment. Hepatitis C treatment, which it's curative in 8 to 12 weeks, all oral therapy. Yet there are restrictions in place from insurers that range from requiring GI docs or infectious disease docs to treat you, saying that you have to have severe disease before you can get treated, even though it's shown that hurts people and leads to higher rates of severe disease and mortality. All of that is put into place, and so we have to remove those systems, even in the hodgepodge, that create an environment of injustice. And I think that's hard. The other, I would say, just as a physician, is that it's really hard to be a doctor right now. There's extraordinary pressures of the healthcare industry to see patients very quickly and to essentially save money. And so what happens is doctors don't have the time to set the relationships with the patients to be able to give that extra moment where you can find out something that the patient may be uncomfortable talking to you about, to do a sexual history, to really develop the relationship so that in the long run you are providing the public health or the health, the preventive care issues that you want. That doesn't happen. So systems change, I think, is a lot of what could move us forward.
Yeah. Okay, great. Dr. Gayle.
Well, I would just, echo, I think that bridge of preventive health to public health is important. And because there's no financial incentives for preventive health in a clinical setting, that bridge between individual medicine and population health never really seems to be made. I also think that public health needs to continue to do a better job of explaining the benefits of public health. When we do our jobs well, nothing happens. It's we are the quintessential non-event, if you will, if we're successful in public health. In individual medicine, you have somebody who is ill, who is totally, kind of incentivized to get treatment. And I think we need to do a better job of demonstrating why the absence of disease is as important to benefit as curing somebody when they have a disease. And so I think there's just a lot more we need to do. And if we can elevate public health in people's mind, I think we'll also have a better opportunity to integrate individual care with public health and the public health system. And again, I think, the payment issues are incredibly important as well.
Great, thank you. And here's a question from a Columbia Cup Scholar 2013 and a current DRPH candidate at Morgan State, focusing on HBCU Black women's uptake on PrEP. And this question is for both of you, and it is, as we think about sustainable solutions and the need for increased diversity, equity, and inclusion, how can we continue to give those that look like the epidemics we are trying to address positions of leadership, change, and power? So, Dr. Merman?
Well, I think, Dr. McCree, as you know, that's been a strong effort within our center, and we've had some success. We just did an analysis internally that looked at our workforce. And as Dr. Gayle mentioned, what gets measured gets done. So we've shown a 20% increase in racial and ethnic minority staff over the past decade. We already are over 50% of our staff are racial and ethnic minorities. And we've seen that that's we have increased the proportion in the higher GS levels, but we have not reached the levels that we would like particularly at the GS 15 level. But then we also did a survey with staff about sexual orientation and gender identity, and we found that 18% of our staff are LGBTQ, and that it is completely even across GS levels. So people are being, either promoted or hired through what appears to be, a method that is non-discriminatory. So I think for that particular factor, but I think continuing to look at these data to improve where you need to improve. And there is one, large gap we have, which is with Hispanic and Latino employees, where it's about 4%, which is well below where we should be. And to try to change the system in human resources and outreach and recruitment and selection and all the processes that need to happen so that we can do that over time and treat it as urgently as it really is. It's an urgent issue. And so I think we've had some success, not enough, and maybe that honesty also comes into play. But I think that it's really important that becomes a priority, and that people use their creativity to think about how we can get this done. And I also think that relates to one of the other questions about increasing racial and ethnic minority physicians in America, and how do we get that? How do we do that? Well, that's been a long understood as an issue that would benefit the nation's health if we could fix, but hasn't happened. And so I think hopefully the same kind of approaches can be made with regard to that, and understanding some of the factors that Dr. Gayle has highlighted, which is a lot of it is economic and the structures of higher education, and what does it mean to be able to access all of the education and other kind of social and economic determinants from childhood, so that we don't have these disparities when we measure them at the physician level.
Great. Dr. Gayle, anything you want to add?
I would just
Nothing to add there.
I know we've got lots of questions, so
Me too.
Yeah.
And we won't get to the 47 questions that we have in our Q&A, which is wonderful to have such an engaged audience. But let us close out with just this one, in terms of the fact that we're living in a world shaped by all of our collective experiences with COVID-19. And we know that it has changed, or exacerbated or shown a light on the disparities that we see. And I guess I'm going to ask now, what are some of the similarities and differences between the COVID-19 response and the HIV responses? You both were a part of that, and some of the lessons you learned in terms of lessons learned for advancing equity, when you think about those similarities, those differences, and some of the lessons that we learned.
I'll let you.
COVID-19 resulted in a whole government and whole society response within weeks. HIV took years. But misinformation, fear, and politicization of public health occurred for both epidemics. In the beginning of each, we were unaware of exactly how each pathogen was transmitted, and we made errors. However, with COVID-19, public health communications tried to avoid stigmatizing persons who had COVID-19, and I think that was generally effective. That was not the case for HIV. So our response to monkeypox has been more similar to COVID-19, and I think we've learned from that experience. It's generally careful and informed, and I think that's a sign that that public health and this agency are thinking carefully about those facts. But we are still dealing with the ramifications and current stigma and discrimination related to HIV that I don't think we've seen with COVID-19. And I think learning about that and how we can both do the things we did with COVID-19 wrong better next time, but also the things we did with HIV, not repeat the mistakes and to repeat the good things.
Yeah, Dr. Gayle.
Yeah, I would agree with that. We responded a lot more rapidly. And I think we learned some of the lessons from HIV and addressing the HIV pandemic, and perhaps were more attuned to some of the disparities earlier on. But I also think, there are differences. There is a difference between a sexually transmitted disease and a respiratory transmitted disease. And so, I think it says to us, we've got to think about health in a unbiased way. It doesn't matter how one contracts a disease. We're dedicated to reducing the health burden on populations across the board, and particularly populations that are oftentimes the most impacted. So I just think this, how do we think about health in a broader context? How do we think about it in a non-stigmatizing way so that everyone gets the help that they need? And I just think there's lots of lessons, both in terms of the similarities, but also in terms of differences. I would just, one other, if you allow me, I saw one of the questions around the issue of reparations.
Yes.
And I just wanted to address that because I think it's, it's an ongoing topic. And as I think about these broader ways in which we think about society, I think we have to start having bold conversations about how do we think about the biggest barriers to people's health and well-being, and are there ways of addressing it? I just did an op-ed on reparations and talked about reparations as an investment in our future, and not thinking about it as, are we advantaging one group over the other? We know that we cannot, without bold action, address some of these disparities that have existed for not just decades, but centuries now. And that if you compound the disadvantages and obstacles that have been put on the path of groups within our society, we cannot get to an equal society without thinking creatively about big, broad solutions. So while, I don't think anybody has the exact answer, I think we have to push ourselves to be bolder if we're going to have the kind of impact that we want. And just finally, I want to say thanks to everybody who has congratulated me on my next step. And I look forward to rejoining the Atlanta community before very long.
Yes. And thanks to both of you for a wonderful discussion, very thought-provoking. We learned a lot about what needs to be done in order to advance equity. You talked a lot about making sure that we focus on the drivers rather than the markers, and that the approach will take multidisciplinary partnerships, and we'll need to involve the communities that we serve and need to engage and hear the voices of the communities that we serve. And we need to create efforts that are going to be sustainable. Whatever we do now during this time where health equity is a focus area, we can plant those seeds that will grow into a sustainable efforts, policies, programs, strategies to help us achieve health equity in the work that we do. And thank you for your more than 40 years of service in this area. And I think that the fact that we have these 50 questions here is a testimony to how important it is for us to continue this conversation. So I want to thank you, both of you, for this just an outstanding discussion. We will do our best, audience, to sort of answer some of these questions, typing them, and to get back. I want to thank those who joined us here as well as those on Facebook Live. And now we, next slide, to have a very special presentation. If we could do that, Dr. Gayle, we have a wonderful gift for you. It did arrive, it should have arrived, which is a clock that's nicely engraved on behalf of our team here. And just to recognize and thank you for spending this time with us, and because your service is timeless. So I know your assistant should have the gift.
That's the box.
That's the box.
The box that he told me not to open until today.
That's the box that he told you not to open until today. We hope you'll share it with our audience. It is just to recognize your timeless service in this work and the importance of what's done, and to tell you that the clock is still ticking and there's still much to be done.
How beautiful.
Yeah.
Oh, thank you.
Thank you.
Thank you.
Yeah, thank you for being with us. That's on behalf of us here to thank you, and looking forward to having you back in Atlanta.
And so this, just to say to the audience, it says the Dr. William Bill Jenkins Health Equity Lecture, a man worth remembering,
Yeah.
worth continuing.
Yes.
Couldn't be better said than that. So thank you.
Thank you. Thank you. And now I have the pleasure to turn it over to Dr. Darren Burton, who's going to close us out on this historic day. Dr. Burton.
Thank you, Dr. McCree, for that introduction. And thank you, Dr. Rowley, Dr. Gayle, and Admiral Merman for all of your insightful comments. This event has been a wonderful opportunity to reflect on the need for long-term commitment to achieving equity, as exemplified by the life and work of Dr. Bill Jenkins and many others, including those represented here today. I would like to conclude with a few summary lessons from today's discussion and a brief description of how CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention is putting these lessons into practice. Today, we've heard that achieving equity will require change at multiple levels. From individual decisions to learn about the history and current landscape of social and structural factors that drive health inequities, and to seek opportunities to oppose those forces in our daily lives and work. To community organizing, whether that be in neighborhoods or professional settings, to harness our collective wisdom, skills, and agency to drive equitable change. To the commitments of large and small organizations to re-examine their operations from the perspective of equity and to consciously implement strategies to infuse justice into their organizational DNA. And all the way to large-scale policy changes to combat racism, stigma, and discrimination, and to achieve equitable distribution of health-promoting social determinants. We've also heard that doing this work requires creativity and persistence, as the best path forward is not always obvious, and the road of progress is likely to include some setbacks along the way. And despite the scale of the challenges and the complexity of the endeavor to achieve health equity, we've also heard a strong message of hope today. Collectively, we have made a difference, and we will continue to bring just change to our communities, our workplaces, our nation, and the world. As one example, I'd like to describe efforts by our National Center to foster equity within our organization and to achieve health equity for the populations we serve through what we call the NCHHSTP Equity Initiative. In spring 2019, NCHHSTP began looking for ways to create a shared understanding and long-term mission for advancing equity across our center. A small planning team explored strategies and trainings that could be offered to all staff on the root causes of health inequities, racism, and awareness of the experiences faced by sexual and gender minority populations. As part of this process, NCHHSTP also conducted site visits and consulted with state and local health departments, such as the New York City and Chicago Departments of Health, that had implemented their own equity initiatives and were seeing positive impacts on organizational change and improved strategies for achieving health equity. These real-world examples further inspired us to move toward a more holistic, fundamental organizational change to address equity comprehensively within our organization and to bake equity into all that we do. After 2 years of planning, our center formally launched the NCHHSTP Equity Initiative in February 2021. This initiative connects our existing equity activities, supports the identification of additional opportunities to embed equity into workplace operations and public health programs, and includes a detailed implementation plan. The NCHHSTP Equity Initiative is a transformational, long-term strategy to help us achieve equity within our workplace and eliminate health disparities by addressing racism and other systems of oppression that hinder our center's mission. Although our center has worked for many years to advance equity, this initiative is breaking new ground by intentionally and systematically integrating equity into everything we do by focusing in 3 areas. First, ensuring a workplace culture that is inclusive, collaborative, and anti-racist, and one that encourages all staff to engage in dialogue about racism and other systems of oppression. Second, establishing workplace practices and policies that further increase diversity, ensure fair and equitable opportunities for advancement, and eliminate discrimination. And third, refining our systems and processes for designing, funding, and evaluating research, programs, policy, and partnerships to ensure they are intentionally, systematically, and consistently focused on addressing the social and structural causes of health inequities. Within each of these focus areas, the Equity Initiative Implementation Plan has goals that are supported by objectives and activities, each with responsible parties, target completion dates, and metrics of success. The Equity Initiative builds on decades of successful work by NCHHSTP staff, our partners, and advocates, giving us a strong foundation of proven strategies and bold ideas to advance equity and eliminate health disparities. The NCHHSTP Equity Initiative is, of course, just one example of organizational change efforts to advance equity. And I'm sure that there are many other examples represented among our participants and attendees at today's event. And I hope there will be more such efforts sparked by today's lecture. I personally take tremendous inspiration from today's discussions and would like to exhort all of us who endeavor to achieve health equity. Be bold and innovative, aiming for systemic change. Be inclusive and build community for this work, which requires diverse perspectives and approaches and the shared energy of a social movement. And be resilient and commit to a posture of hope, knowing that the arc of the moral universe is long, but it bends toward justice. Let us all be part of that bend. In closing, I would like to thank the many participants and contributors to today's successful lecture event. Dr. Helene Gayle, Dr. Diane Rowley, Admiral Jonathan Merman, Ms. Ati Pazurai, NCHHSTP's Office of Health Equity staff, including Dr. Donna Hubbard-McCree, Dr. Renelle Miles, Dr. Mariel Marlowe, Mr. Greg Bautista, and Dr. Terica Barnum, and our NPIN colleagues, Robin Loeb and Reed Walton. And thank you to all who have listened and participated in today's event. We appreciate your engagement, your passion, your ideas, and your questions. Thank you again. This concludes our event.